Yeah, I'm not able to enlarge it to the full. Can I go with this like this?
Yes, maybe you can put play.
Yeah, I'm okay. Okay.
Yes, perfect.
Thank you very much. Thank you for the invitation. Pleasure to join all of you. And it's from India, and it's a excellent topic to have a discussion with very nice faculty here. Acute spinal cord injury and the ICU management. It's very interesting to go through that. And most of the spinal cord injuries are very much cared only in the intensive care unit. If you look at this intensive care of spinal cord patients are very diverse in the worldwide due to global inequalities in economy, structures, and availability of specialists. This is most important because when you look at the various managements from different countries, it varies from one country to another country. And so we have as a total, and I found a very nice article written by the anesthesiology groups who are taking care in the critical care management in United Kingdom. The management of acute spinal cord injury, non-specialist intensive care units, a narrative. So this is a very excellent paper, and this summarizes. This is the flow chart of the talk, which I will go through and try to make it as smart as possible. The most important thing is the airway management with the tracheal intubation, which is important for all the spinal cord injury patients, particularly with is associated with the brain injury. And when there is a respiratory failure, which is about to be seen or you expect so, then you need tracheal intubation, high cervical spinal cord injury, and also to facilitate surgical intervention in acute period. So the tracheal intubation is very important and it has to be as early as possible. The next thing is that about the intubation technique, very important, and we have to see that the cervical spine is not dislocated further and cause more impairment to the spinal cord injury. So the technique is depending on experience base clinician and also assessed by for each case individually. This is an important thing, check intubation, and it's a great part altogether, but we should know as surgeons, we should know about it. Subsequent to intubation is the tracheostomy. Tracheostomy is very important, particularly in very high-grade quadriplegia like Asia grade A and Asia grade B cases which needs tracheostomy because they are going to be in the critical care for a very long time. Injury at C5 and above. Obviously, the Center for Innovation, which a phrenic nerve takes, is about C4. So we all know about that patient will have respiratory failure. Increased injury severity, as I told earlier, and also when it is associated with the brain injury, with a Glasgow coma scale of 8 or below. When there is thoracic injury associated with, very commonly we see a combination of head trauma, cervical trauma, and thoracic injury. So all these things which needs more care, finally we treat these patients with a tracheostomy. Then it comes to about the ventilation strategies. Mechanical assist devices are very important with aggressive physiotherapy. The physiotherapy started from the time of admission of the patient in the critical care unit with high tidal volumes of 15 to 20 ml per kg and zero positive N expiratory pressure. PEEP is very important that need to be adjusted as needed. And whenever the strategy is made for ventilation, then there is also the plan for weaning also. So this is very important. It is very difficult, and neurocritical care specialists They have a lot of protocols for weaning process. Apart from the ventilation, we to the blood pressure, because blood pressure is very important associated with hypertension. So the target mean arterial pressure must be approximately about 85 millimeter mercury MAP for 5 to 7 days continuously to prevent hypoperfusion injury site and prevent a secondary injuries. Euvolemia and vasopressors, particularly about noradrenaline, very essential, and that need to be titrated very well. There are so many things which at the research level is individualized perfusion and microdialysis. They are not in practice at present in many places. Maybe in research centers, they are being practiced. Maybe research is being done on that. Most of the thing is done with euvolemia and vasopressors. The weaning of the ventilator after that is depending on so many factors. The weaning fails when it is, and it is defined as the failure of spontaneous breathing trials or the need for re-intubation within 48 hours following intubation if you do it very wrongly. So a simple weaning is completely different from difficult weaning and prolonged weaning. So these are the aspects which we have to take in care while we treat the spinal cord injury patients. Weaning out also takes the part of the respiratory weaning strategy. And the strategy must be start in supine position and then in the sitting abdominal binder, which is very essential, with the secretion clearance. So if you look at that, it's a combination of not only the clinical practice, but also with the nursing secretion clearance. And the weaning out is should be aimed at vital capacity of 5.8 ml per kg. Spirometry, ABG should be routinely taken up. Patient should be afebrile, should not have any atelectasis, should be a clear lung field, clear secretion management strategy. All these things are necessary for weaning out of these patients from ventilation while the patient is treated for spinal cord injury. Also, the cuff deflation of the trachea is a big challenge to many of the clinicians. So it is a very important thing to think about. That apart from that, one point which we see is about autonomic dyslexia, though it is not very acute, but they do see in 5% of the cases in acute stage. Usually maybe associated with CVS, with myocardial infarct, atrial fibrillation, premature ventricular complexes, and AV conduction failures. As far as CNS is concerned, they may have CVA, headache, seizure, encephalopathy, sudden anxiety and apprehension, visual retinal detachments, visions, and pulmonary edema. It is a very, very uncomfortable situation. Needs a sit up and loosening of the clots, investigate and treat precipitants. If the bladder is distended, you need to flush out the bladder, lead a catheter, avoid rapid emptying, check the testicular torsion in case it is there, fecal impaction, manual check, laxatives, evacuation, and check fishes. Is also an important subject that will come to later with pressure soles also carry a lot for autonomic dyslexia, which need to be taken. During this time, that ASIA score has to be analyzed every period of time to assess the patient is improving or not. So this has to be standardized all over the ICU management. To come to the pharmacology, where the pharmacology is absolutely not being be taken out of spinal cord injury. It's a big controversy because it's been going through since 1960. Methylprednisolone was being advocated in an earlier period, and then NASIS-3 came out with intravenous MPS about 30 milligram per kilogram body weight in the first 15 minutes, followed by 45 minutes of pause, and 5.4 milligram kilogram of body weight for the next 23 hours. So this is the concept which came in the recent Green Book. This Greenberg's book has mentioned very interesting point. I would like to come to that a little bit later about methylprednisolone. So the world is divided whether to use methylprednisolone or not. As in this article, you can see the article has seen the results 26 weeks, and they found that it did not have any demonstrate any enhancement in the neurological recovery. So it is being found it is not very useful. And this is a Korean journal article which came very recently to say that no, we should not use MPSs and we should encourage others to stop. So there are so many papers which are coming like this articles. But however, we have Michael is to talk to next, and they did the very elaborate study. In 2017, they come forward with a very beautiful. This one you can see that here, take is comes of they offer to adults. They come between less than 8 hours of injury, and you can give a 24 hours infusion as an option. So this was given by Michael's group. And subsequently, we came from WFNS Spine Committee, and we came with the consensus that selected young patients with no comorbidity should be given the opportunity with methylprednisolone. So the world is divided in so many ways. And another paper came recently by Chong, and they said that we are not only seeing about a grade 0 quadriplegia, that is a complete spinal cord injury. We also have to think about the incomplete spinal injury patients, whether MPSS is useful in those conditions. That is another one. And finally, there's a very big paper on this, analyze the guidelines, which included our paper, our work in WFNS Spine Committee, also Michael's article is also here. And they came with the conclusion. There were inconsistency in the recommendations of methylprednisolone. The evidence-based recommendations tended to recommend against using MPSs, whereas when you do have a consensus recommendation, they tend to recommend for. So that is the reason Greenberg book has written, saying that 56% of their questionnaires consultants agreed to use MPSs. So it is divided. Now, just a case example here. Here is a patient who came in the recent with the spinal cord injury. Here you can see came with incomplete, looks like incomplete with upper limb 1.5, lower limb by 3.5. And this patient was given with MPS as per necessity, the dosage. And then for some reasons that they had to be taken the surgery of 4 days. And this patient is actually doing well. Now,
Good.
now I do not know where exactly to put this patient in line.
How are you?
Whether this
Good.
the
Sit down.
decompression
Please
has
take
to, or the decompression has done the work,
Moment.
or incomplete
How do you
injury
feel?
has done
நல்லா
the work.
இருக்கீங்களா?
But
You joined the
finally,
army?
as human beings, we have to think about it.
Joined-
We have to give
Where are you now?
benefit
Jammu Kashmir.
to the patients, whoever is eligible, that without any comorbidity. So that is very important in concept. One can have a blanket say to MPSs. MPSs can be given in select cases when the patient is very young, when there is no comorbidity and no other injuries, isolated spinal cord injury. Very well. Here you can see in the post-op MRI, you can see the healing has happened very nicely, decompression, spinal cord very beautiful, and there is a small vacuole that shows that the patient had a contusion here, not just a concussion that he came back. So there was a spinal cord injury, but maybe it was incomplete at that point of time. The other point which I would like to emphasize is venous thromboembolism. We've seen at least 8% of the patients in spinal cord injury in ICU. The low molecular heparin has to be started within 48 hours, and it is recommended very strongly to continue for 8 to 12 weeks, is 2 to 3 months. Pain is very, very disturbing for the patient, both acute and chronic. So the musculoskeletal, it is due to the existing injuries, immobility and instability of the spine can cause severe pain. So one need to have a multimodal approach for that. Surgery, if needed, as our previous speaker said, surgery needed, it has to be done. Peripheral nerve block, paracetamol, NSAIDs, and titrated opiates can be given. The visceral pain also maybe have to be seen carefully because of urinary tract infection, constipation. This has to be taken care in the ICU. Neuropathy pain, which is about in 56% of the patients. This can be the level of injury or below the injury. amitriptyline, pregabalin, gabapentin, and duloxetine. They are some of the medications along with anxiolytics and antidepressants are very useful in reducing the pain because it's very, very discomfort when a patient has a pain with the neurological deficit. This also should be taken care in the critical care patient in the ICU. Pain specialists will be of very great helpful in these patients. Finally, we have the rehabilitation, which needs the management of necessity, the patient's psychology, the mood, communication with the patients and relatives, readiness for discharge to rehabilitation, and then we need to prognosticate the patient. I thank you for listening to the talk. Finally, I would like to say one point. ICU is the important place that apart from surgical, our skill, but ICU is the one place where it is going to change the patient's complete outcome. Thank you very much. Thank you.
Thank you. Thank you very much, Professor Parthiban, for your excellent presentation. So